So as you can see, I'm rolling up my sleeves. I'm going to be wearing many hats today. I'm actually going to be the patient for our next scenario. So as we go ahead and get restarted, the person I want to introduce is Errol Ozdalga. You've already heard a little bit about him. But what he's going to be talking about today is our Stanford 25 sessions. He's going to walk you through that. And I just wanted to make sure that he gets all the credit he's due. Kind of as Abraham alluded to earlier, he's really been the guy that got these sessions off the ground. Before he joined the group, it was Abraham, myself, and a few other people trying to do sessions here and there. But what I cannot emphasize enough is what took us to the next level was having Errol come along to actually get us organized, to build a network of folks who were interested in teaching, who had built up a repertoire and could do these sessions, and to make sure that we do it on a timely fashion where people expected us. That actually took us from just doing a handful a year to actually doing them every single 2 weeks. And so it's just been wonderful. Errol's really done all of that work, and I'm so happy he can share this experience with you.
Okay. Hey guys. So not true. Actually, we all do this together, our huge group, and we just go around always patting each other on the back and saying, you know, it's all you, it's all you. That's what we do. But honestly, it's a group effort, and you actually see, I have proof of it in my slides. I'll show you that this is truly a group effort, what we do. So thanks for having me up here, guys. I'm really excited to get to meet all of you. After hearing all the speeches this morning, you have Steve McGee, you have Abraham Verghese, John Kugler, Andy Elder. You can see why I asked them to put me speaking at this time. If I put you guys to sleep, I'm blaming it on food coma. Right? So what I want to do is talk a little about our Stanford 25 sessions. Actually, Andy Elder did a good job of helping us organize kind of the different types of teaching we do. You saw this morning Abraham talk about the 5-minute moment. And he's kind of talking about, 5 minutes. We don't have much time to really teach, and how do we do it efficiently? And that's really kind of us describing teaching on the patient wards. When we're caring for patients, and the residents are getting 20 pages, and they have to go spend half their day in front of electronic healthcare records. How do we teach them and make it meaningful? Well, that's the 5-minute bedside moment. Then we showed John up on stage with medical students, and kind of our analogy for afternoon rounds or afternoon bedside teaching, where you maybe have more than 5 minutes. You have maybe 15, 20 minutes, sometimes more. What I want to talk to you now is our classroom teaching, the 1 hour that we spend in dedicated classroom time where theoretically our learners are not getting pulled to do other things. They're actually able to hang out with us and spend a dedicated amount of time learning bedside medicine. So what is the Stanford 25, the Stanford 25 sessions? They're hands-on teaching. They occur in a classroom. We generally they last, for the ones that we do at least, they last for an hour. They occur every other week, and they're in place of our morning reports. So of course, as I think everybody here knows what morning report is, but a couple people may not know, morning report is just a case you're presenting. A resident comes in and talks about a patient. Now, sometimes really, really keen residents will bring in images or do something a little more hands-on when it comes to talking about that case. But for the most part, you're just presenting the exam. And half the time, the person talking about the exam didn't even actually do the initial exam that they're talking about in the first place. What we're doing is we're doing hands-on teaching session, and we're doing one new session, one new topic every session. We do it year-round. Simplified, the goal is just this. We want them to walk out of this session having gained a new technique, having more confident in one physical exam technique that they didn't have coming in. And if they were pretty good at that technique in the first place, we want them walking out feeling more comfortable teaching at the bedside. So the exams are highly variable. They vary depending on the type of exam you're teaching. So dermatology, sometimes we focus more on observation, although you can make an argument that dermatology is just as much palpation as it is observation. But we've done sessions where we've done just images. But then most of our sessions are with real patients. For example, the abdominal exam. We found that the abdominal exam is one of those teaching exam sessions where if you don't have a real patient in there, it gets kind of boring really quick. And so you want to keep, and I'll talk about this more, one of the goals of teaching the physical exam is keeping your learners engaged, keeping them excited, because it's one of those things where they learned it as early on medical students. At some point, somebody's talked to them about it. How do you make it more valuable, and what are ways you can do to make it more engaged? Okay. It's a collaborative effort. It is tremendously a collaborative effort. We actually, so when we first started off doing these sessions, it was just a few of us doing the sessions, and we do them, as Abraham mentioned earlier this morning, we do them here and there, maybe once a month, occasionally once every couple of weeks. And it got to the point where the residency program was really wanting us to do more of these. And we realized we couldn't do all these sessions, just a few of us, year-round by ourselves. So we actually started enlisting different faculty throughout the Department of Medicine and throughout the campus, as well as faculty from outside our campus. We have here Dr. Saul Rosenberg, one of the most well-respected hematologists on our campus, leading a session on the approach to the lymph node exam of a patient with chronic lymphocytic leukemia. Mindy Nguyen here, one of our liver docs, who's leading exam on the abdominal exam, session on the abdominal exam of a patient with end-stage liver disease. This guy had really, really huge liver and spleen, and the residents got a great opportunity to examine this. This is actually Andy right here. A year and a half ago, he was out visiting us from Scotland, and he led a really cool session on the approach to the lung exam, but he focused on differentiating from vesicular versus bronchial breath sounds. It was a really cool session that the residents really enjoyed. These are some of the topics we do, and I won't go through all of them. You can find them on a lot of the topics we cover on the website, but we also have a lot of topics that are not on the website that we plan to add content for. I'll talk about that later, that we do sessions on. So we'll do a session on anything if we can find the person to lead it. We certainly don't do a session on everything that's in the 25, for example, and if anybody can help us with this, we haven't figured out a way to get a real patient in and teach the rectal exam. But if you guys come up with an idea, please let us know. I actually, we thought about reaching out to one of our surgical colorectal surgeons. Like, maybe they'll be great at teaching the rectal exam, and they might be able to find a great way to do this in a teaching room, in a classroom. So I emailed one of our surgeons, and like a year later, I'm still waiting for replies. I don't think they found out the answer either. This is an image I actually found recently in the Stanford archives. We have this great repository of images from 100 years ago. This was taken in about the 1940s. This guy on the far right there you see is Arthur Bloomfield, one of the previous chairs of medicine, really well-respected man who was known for bedside teaching. And it was pretty cool because I found this image and I realized this is a Stanford 25 session from the 1940s. Even back then they were doing it, and certainly they were probably doing it much better than we do now. You could see one of the residents here with a patient, and you can kind of begin to see, I'm assuming there's a big classroom full of people in the background there. But what we do now is our goal isn't simply to talk about how medicine sucks now and we want to go back in the day where it was amazing. Our goal is to take what was amazing back in the day and combine it with which is wonderful now. And I think you've already seen a great example of that earlier today with technology and how can we use technology to bring people back to the bedside. As you guys all know, most of the students or residents today, as soon as you bring some sort of gadget out, they totally wake up and they're really interested in it. And gadgets are one way we use to engage the residents. I'll actually do a demo using gadgets in just a few minutes. One of the sessions we've done in the past is a focus on promoting the students to become the teachers. This is an example of an ankle brachial index session we did. And what we did here is for the hour session, we broke it up into two 30-minute halves. The first 30 minutes, we took the senior residents and taught them something a little more technically difficult. And then we took the junior residents, basically the interns and the students, and we taught them something more simple, just to keep them busy for half an hour. And then after that half an hour was over, we combined the two groups, and we had the senior residents, teach what they just learned a few minutes ago to the medical students and the interns. And you kind of see here, this is Kelsey, one of our previous residents, and she actually was learning how to do an ankle brachial index, and literally just in a few minutes, she's confidently teaching a full table full of interns and students. And this is something that got a lot of great feedback from the senior residents. We use real patients. I'm going to mention this a couple more times because it's one of the most important things we do. We use real patients in the Stanford 25 session. This is a patient with splenomegaly. The residents during the session commented and said, listen, this is my first time examining someone with an enlarged spleen with somebody else. I've never actually had somebody do this. The patients get so used to this. At the end of the session, he was actually telling the students if they were doing it right and telling them how to examine him in the first place. So it's a really valuable session. This is Poonam, who's going to come up and speak in a little bit. This is an example of how we'll take any patient we can get. This patient is Poonam's husband, he injured his ACL and became, it was a bummer for him, but it was great for us because he became a great patient. And this is actually an amazing session she did on the approach to knee pain, the outpatient knee exam. And this is me doing a session on peripheral arterial disease. That's my dad. He's got bad circulation, so I made him come on in and be a patient, and we taught the residents how to do the approach to peripheral arterial disease and ankle brachial index. So standardized patients, as you saw, we've used some standardized patients, and we'll also be involving real patients during the symposium. They fill really important roles as well. Sometimes they actually are better for certain exam topics than real patients because, one, they're professionals. The standardized patients we use here, and we can certainly talk, I'd love to hear if you guys use them yourselves. Our patients they're actors. Their other job is a lot of them are actors, and they actually can play really great roles, whatever you need them to play. And as professional patients, they give really great feedback. They're really trained in giving feedback to the learners. And this is actually Andy again leading a session on the exam of the trachea. He's got some really great exam topics he does. So after every Stanford 25 session, we do surveys. And this is just a couple quick slides on the results of our surveys. So most of the people in our Stanford 25 sessions are R2s, R3s. We try to target, one thing I don't think any of us have mentioned yet is the target of our information is for resident. We want it to be available for everything from medical student through faculty, so we make the goal of the target being the resident because we're not just teaching the knee exam, we want to teach the approach to knee pain. We want somebody to learn from the exam such that if a patient actually comes in, they can do something valuable with that information. There's videos out there where you look at it and you're like, okay, I know how to move the knee, but what the heck am I supposed to do with that information? We want something to be really valuable, and that's the way we try to approach. We actually found just by changing the name of the session from knee exam to approach to a patient with knee pain, it actually frames the way we teach completely differently. So mostly our 2s, our 3s. We ask them a few simple questions. Did this help me improve a clinical skill? Yes. Has this helped me improve the ability to teach others? For the most part, everybody says yes. And I just wanted to show this to you, not to toot our own horns, but we want to just share with you, and I'll make another case, that this teaching is extremely well received. I think a lot of you guys have already experienced that, but I want to keep pushing that because a lot of you guys are going to start something similar to this. Many of you already have stuff like the Stanford 25-year institutions, but a lot of you will be starting this. And one of the barriers I've seen is just kind of reminding yourself that this teaching is really helpful and people really appreciate it when you do it. Our residency, actually the biggest problem we've had now is trying to find more time to do more sessions. It's a good problem to have. And overall, we get good feedback on how things go. So I want to just talk about the things that we've learned. So we've been doing these sessions now for about, I think 5.5, 6 years, and we've been doing very frequently the last 2 to 3 years. And we've learned a lot of things along the way. My goal, if there's one goal for me getting on stage and talking to you, it's to hopefully share with you the things that we've learned so if you're doing this or plan to do this, you can benefit from it. So, we've learned there's certainly challenges. There's time, and I want to just acknowledge we have a lot of, thanks to Sonu, who's helped organize a lot of everything that we do, we have a lot of great pre-medical students that play a huge role in organizing everything we do. They help coordinate the patients, the facilitator, if it's not one of us leading the session, paperwork that could be associated with it, and just making sure everything runs really well. There's all those challenges with time to practice and teach, and I'll talk more about that, but making sure they have opportunities to practice in the session and there's enough time to do that has been an issue. Certainly when Abraham speaks, you tend to get a full room pretty quickly. And space is definitely an issue sometimes. You see, I'm just showing this picture because you see people standing on the tables behind trying to get a view of the exam. And that's been an issue that you have to be mindful of, and I'll talk about here coming up. Of course, sometimes you get enough people in a room, they find interesting ways to deal with it. This is a picture from Taiwan, actually. Really smart guys figured out a way to do mass thyroid examinations. Things that we've learned is this teaching is, one of the things I love about it, it's for everybody. We do these teachings for students that aren't even in medical school yet. This is a picture of Maya teaching the shoulder exam, and she broke it down in such a simple way that the students walk away just simply excited about going to medical school and not even knowing exactly what the joint exam is about. We do it for preclinical students, so we lead a Stanford 25 version for our first and second year students. And basically the goal is, more than anything, is just get them excited about being in medicine and get them to appreciate the importance of the physical exam, so when they get to the point where they're seeing patients more regularly, they appreciate it more. And of course, clinical students. This picture you've seen before, we do the bedside rounds, and of course that's been talked about. So we teach for students of all levels, and of course residents and faculty. So things that we've learned as well. Setup is important. This one's almost kind of like, well, duh, setup is always important no matter what you're doing. But it's actually one of the most common overseen things that we've noticed in teaching the exam. You have to always make sure everybody can see. And this is something that we've gotten to the point now is when we do our sessions, we have a key person. It's not the facilitator, it's somebody else. Their job is simply to make sure things are organized and the setup is right. And if the session is started and people are in the back and you're kind of losing them, they're falling asleep, or they're just not standing there, we call them out and we get them to the front. And we got to the point now where if the front row seat is empty, the people in the back, we call them and bring them up. Or even better, we have them standing around and not sitting at all, just like this. So Steve actually did a great job of this earlier. It really demonstrated engaging people, and he was kind of moving the head, and all of a sudden half the crowd here is moving their head doing the exam with him. This is what you should always be doing when you're teaching the exam. If it's possible, engage the audience and get them to do what you're doing, even if it's something simple. It makes it more fun than them sitting there and just looking at you. This is actually a session on the approach to the bone marrow transplant patient. And this is Dr. Everett Meyer, one of our BMT docs, going over that with one of our patients who had a remote transplant. This is Dr. Baldeep Singh doing, he does a really awesome session on the approach to hip and back pain. And sometimes you need slides. And so he certainly has to do slides for something like this because he's got to talk about the anatomy before he talks about the exam. But on the flip side of it, you want to make sure you don't have too many slides because at the end of the day, the magic of this teaching isn't in the slides or the handouts. It's in the demonstration and in the practicing of it. And this is also something that personally, when I first started doing this teaching can be kind of nerve-wracking. It's a little daunting to do sometimes. And there's a tendency for people to just come in with like 50 slides and just kind of fill the time with their slides. And you want to keep away from that as much as you can. Stay away from the slides and let the teaching be done at where the patient is. This teaching is certainly very unpredictable. This is the knees of one of our chief residents. We were doing a Stanford 25 session one day on, I think it was ankle brachial index, and he hobbles in, and we're like, dude, what are you doing? Why are you hobbling in? And it turns out he had this left knee, if you can see, it's a little more swollen. He ended up having a pseudo gout attack. And the session went from being about ankle brachial index to the approach to the acute knee. And we ended up learning more off him than we did on our original plan. So bedside teaching certainly can be unpredictable. It's sometimes nerve-wracking, but usually one of the best things about teaching the physical exam. Enlisting other faculty, again, is very crucial. This is another doctor Dr. Mark Genovese, doing a rheumatologist who is teaching a session as well on the acute knee pain. And challenge them. One of the best techniques that I've seen done is when you're teaching a Stanford 25 session, when you're teaching a bedside exam session, is don't spend as little time as you can talking. Spend more time engaging the learners. I love it when people call the residents up and put them on the spot to do the exam. Number one, it gives you a sense of what they know or they don't know. Sometimes teaching the exam, one of the things that, at least when I teach it, that I worry about is if I'm teaching them something they already know. And when you get them on the spot, you clearly set the tone for the room that they don't know as much as you worried that they might know or that they think they might know. And you also really engage the residents. There's something about peers seeing each other get put on the spot and doing something like the exam that really gets them more engaged as well. And of course, let them practice. This is, I kind of mentioned before, but we think of teaching the physical exam as teaching a procedure. So if you are teaching somebody how to do a thoracentesis, you're surely not going to just let them watch you do it and then send them off to do it on their own. They have to watch you do it. You have to watch them do it. And then ideally, for the really learner, they have to teach it themselves. The physical exam is nothing different than a procedure, essentially. You have to let them do the technique, even if it's something very basic and simple. And I mentioned earlier, tell a story. Physical exam teaching for us, and I think for a lot of you, isn't just teaching some piece of knowledge. It's really sharing your experience. It's sharing the type of doctor you are. And telling a story allows them to realize why you're teaching this in the first place. What does it mean to you? Why is it so valuable? And oftentimes, one of the most entertaining parts of learning the physical exam, it's essentially our Stanford 25 sessions are essentially 1 hour, 5-minute bedside moments, so 60-minute bedside moment, essentially. This is Junaid Zaman, who just got here a little bit ago before lunch, and he's one of our, he's a cardiologist. He is a great teacher, and he recently led this session on the approach to acute cardiac, basically the cardiac exam and cardiac heart sounds. This was a patient who been in the hospital for a few weeks. He ended up developing endocarditis, and he was stuck in the hospital waiting for a heart valve replacement because he developed acute AI secondary to his endocarditis. Despite being grumpy, instead of being grumpy, he was a tremendously wonderful person and was more than happy to be wheeled across campus from the hospital into our teaching session and be our patient. What really struck me about this was at the end of the session, the family who also joined us just was so excited, and they jumped in and said, "Hey, Dr. Zaman, can we take a picture with you?" And I took the picture. And it was almost as if Junaid was their doctor. You could have sworn he was their doctor for the whole time he'd been in the hospital or even longer. And it really sent home the message that this type of teaching is an opportunity not to just teach the exams, the opportunity to teach the kind of doctor you expect your learners to be. And it also sends the final message that patients are priceless. This is the golden arrow in your teaching the physical exam. If you can get patients involved, they usually are more valuable to teaching the exam than anything else you can do. So always get patients involved. The last thing, the learners appreciate you. They really appreciate you. And again, it's something I like to emphasize because it's easy to get to the point where you know the exam's exciting. I've already talked to people about this. You know the exam is valuable, but you're just not doing it for whatever reason. And I always find that just remembering that this is an extremely important thing and the learners appreciate it maybe helps get that done. So what I'd like to do now, actually a couple quick slides. I think you guys all know we have the Stanford 25 website. I'm not so much trying to plug it as I'm just trying to let you know a couple things. One, we're really excited about building on it. We want to add more content to it. We have actually more content on the way being added to it and updating the design and all that stuff. But two, this is like a golden opportunity for us to interact with all you guys. You guys, this is a room full of just amazing experience and knowledge, and we want to collaborate with you as much as possible. If any of you guys are interested, please let us know. We'd love to be involved with you. You'll have my info, and please let me know if you're interested in collaborating. I'd love to talk with you more while you're here or later on. Of course, we have social media on the blog as well, just to point that out. So what I'd like to do now is we're going to actually do two demos, two relatively quick Stanford 25 sessions. They're not going to be 1 hour each. We're going to just go over what we teach, a couple examples of what we teach for Stanford 25 sessions. So John, as he mentioned, he's going to be going from the session director, symposium director to patient temporarily. And we're going to talk about, the first session we're going to talk about is the fundoscopy exam. So one of my favorite topics to cover. So just really briefly, I think you guys all know the optic disc, the back of the retina. Optic disc, optic cup, fundus. We're going to focus on the optic disc and optic cup area. And I just briefly want to just share with you a case. This actually was a case from when I was a resident about 7-8 years ago, and I was in ICU, and I get a call from the ER. And the ER resident calls me and says, "Hey, Errol, we got a patient with pneumonia. He looks a little septic. We think you should maybe spend a night or two in the ICU. Can you come down and admit him?" So I come down to see him in the ICU. And he's really somnolent. He's kind of groggy. He's just not waking up, and there's no family around, so I don't know if this is baseline, but I kind of assumed it wasn't. There was a Panoptix, a fundoscope down there, and so I grabbed one of them, and I took a look in his eyes, and ended up seeing this. I actually took my little Android phone at the time and stuck it up against there, took a video, and cropped that out, and that's what we saw there. Anybody know what that is? What do you think his diagnosis was? So this is part of this is a very blurry picture, but basically this is supposed to be his optic disc, and his whole optic disc is blurred in this area here. And what you're seeing here are flame-shaped hemorrhages around there, which you oftentimes see when you have swelling around the disc. So he basically had concern for increased intracoronary pressure. He ended up having papilledema based on this. So from that, we assumed he had meningitis. Not only did he have pneumonia, he ended up getting diagnosed with meningitis, pneumonia, and growing strep pneumonia in his blood. And it changed our management significantly because we ended up giving him antibiotics and steroids. And this was an example of, if I hadn't looked in his eyes, I'm not sure if I wouldn't have just kind of started him on, as the ED had planned, on antibiotics and just get him set to come up to the ICU. And it's like one of the cases I use. I have a few cases, but it's one of the cases I use to demonstrate to the residents that this matters. Being able to do something as simple as an internist to look at the optic disc can make a big difference in your ability to take care of a patient. So what I'd like to do is simply just share with you, how I teach the fundoscopy exam. Is anybody comfortable with looking in somebody's eyes or using the Panoptic? A few people? I usually ask the residents this. Sometimes I'll ask the question, have you ever looked in an eye? And everybody raises their hand, and I'm like, oh crap, everybody knows how to do this. Then I ask the question, is anybody comfortable using it? And nobody raises their hand. I'm like, okay, thank you, let's teach it. So what I'd like to do first is just kind of briefly go over what the scope is, how it works. When I was a medical student, I had this really awesome mentor, and he's so enthusiastic. And that was back before Panoptix. We used the little traditional direct ophthalmoscope. And the teaching there is you got to get really close, and you stand back here, and you kind of get closer, and you focus, and you slowly lose the personal space. The right arm, right eye, right side. And then you get in here, and then he'd always scream. Then you get in, and you go pivot, and you pivot around, and you look at the retina. And he was so enthusiastic. My other students and myself would look at him and be like, oh, that's so awesome. Look how excited he is. We can't wait to see. We grab the thing, we go in there, and we're in there, and he's like, are you pivoting? And we're like looking around, and he's like, do you see it? Do you see it? And we're like, yeah, this is awesome. And then he walks out, I'm like, dude, I didn't see crap. So the nice thing about the Panoptic is you can see more. And they're not paying me to say this. It's just easier to see. The cool thing that we have is a iPhone attached to the Panoptic. So we can actually see if they're actually seeing something or not. So I'm going to attach this to, actually, before I do that, I just want to briefly go over the settings on that fundoscope. So a couple things here. You have, of course, your power supply. Can you zoom in a little bit more? Okay. So and we can talk, we're going to demonstrate, we're going to go into small group demos to go over this a little bit more, and you can just press the button and turn that on. There's a couple of other settings here. Let me just grab a scope here without this thing on it. Okay. So there's a couple of other settings here. So one is the setting here where you can slide back and forth, and that'll give you different types of light. You can have a medium circle, a big circle, and a small circle. The purpose of that is, I'm pretty sure it's just so the company can charge you more because there's more things to slide through. But theoretically, if you have someone with a dilated eye, use the big circle. If it's in a really bright room, use a small circle, because if the light reflects off the iris, it may affect your view. The truth is, I just use the medium circle, and it works almost every single time. There's a couple other settings you don't need. All you need to know is that the medium circle is denoted by a special green line. All the other settings are a white line. So they're basically telling you just use the green line. That's all you really need. The other thing you need to know is this setting here. Let's see if you can focus it. Perfect. Focus a little bit. So if I go up towards the green, it focuses things in close up. So if I'm looking at something really close, it's like a magnifying glass. If I go towards the red, it focuses things in far away. So I'm nearsighted, and without my contacts, my prescription is like -10. So I'd actually have to go down to -10 to get it into focus for me. So this is actually a poor man's way of checking someone's what their prescription is. If you're 20/20 vision or you wear contacts, you can just put it at 0 and not think about it again. A common question I get too is, do you have to worry about the patient? For the Panoptic, you generally don't have to worry about the patient. And that's pretty much it. That's all you need to know for these settings. You don't have to play that game of adjusting the knobs when you're looking at the patient and as you move. So the last thing to know is simply the technique of using the scope at looking at the patient. So I'm going to connect this to the screen. Okay. The iPhone is 20/20 vision, so I'll leave it there. And I'll ask John to, if you can pop over to that side. Great. And we use this little cup here. I usually go to the patient and like, hey, there's a little cup here. It's going to touch your face, so don't blink so they get used to it at the beginning. And then I come back. And then the rest of it is just simply doing a couple things. One of them is I'm looking for the red reflex. Oh, John, can I ask you to put your left thumb up and put it straight ahead? And he's going to look straight at that thumb the whole time. And I'm going to come about 15 degrees from center. One common problem I see that the students make all the time is you'll have one person who's like 4.5 feet tall and someone who's like 6 feet tall, and they're looking like this, or the opposite, they're looking like that. you want to always make sure you're the same height. And then you come about 15 degrees from center, and you look for the red reflex right there. Great. You guys see the red reflex, the cat's eye right there? The red reflex is great. It does two things. It tells me, one, he doesn't have anything obstructing from his retina to the back of the iPhone camera. So he doesn't have like a cataracts, or obviously he's not the right age group, but like a retinoblastoma. And number two, diagnostically, it tells me I'm in the right angle. And then other than that, you just kind of follow it in to his optic disc. And there's his optic disc there. And you know what I generally do if the first time I'm teaching this, see a little bit of the optic cup there. First time I'm teaching it, I just tell the residents or the students, just try to find the optic disc. If they can do that, fantastic. And then if they have more time, we talk about looking further around the eye. And that's simply all you have to do. Okay, cool. So the next thing so what I'm going to do is just go through both demos, and then we're going to go into, if you guys would like to, we can practice them, okay? Excellent. So the next demo we'll move right over to, so we can disconnect this.
Setting up, just so you know, Errol's done that with me as the patient a few times before, and one of the things he often points out is if you're looking to do a demo, especially in a room that's pretty bright, it's actually really helpful to look around for someone who kind of has big pupils. You know, clearly when you're in your own clinic, when you're at the bedside yourself, you can dim the lights, but when you're trying to do this for an audience, it's really helpful to find someone who has big enough pupils that even with the lights on, their pupils are big enough to see through. So Errol was cheating a little bit, knowing that he can usually find my retina very easily, even with the lights on really bright.
And in a typical 1 hour, if I had 1 hour to do this, I just did that in like 5 minutes. I'll come in with a few more slides, and then I'll take more time about going through the technique. I'm rushing right now, so we have time to practice. We got to the point where at Stanford we're used to, I do the session enough times that the senior residents are pretty good at it. So instead of me leading the sessions, I actually show some slides, and then I call one of the residents up, and I have him or her lead the rest of the session, and then I watch them going around giving feedback to the interns and students on how to do it. Another session we do is on Pulsus Paradoxus. It's one of those exam findings that, or exam techniques that's really great and really helpful at the bedside, and we make sure that every resident knows how to do it. I think everybody here knows the mechanism of Pulsus Paradoxus, but if you don't mind, I'm just going to briefly just go over it. So when someone has cardiac tamponade, searching for Pulsus Paradoxus can be very sensitive and specific for making a diagnosis of cardiac tamponade. Normally, if you don't have fluid around the heart, as you take a deep breath in, more blood goes into the right ventricle, and a lot of that increased pressure is transmitted in the ventricular walls. But if you had cardiac tamponade, that pressure can't be transmitted to the right ventricular walls and the right atria, and it gets transmitted through the interventricular septum and causes an increased pressure in the left ventricle and decreased volume going in there. So naturally what happens is, as you take a deep breath in, your blood pressure goes down more than it would normally if you didn't have fluid around the heart. So what we're going to do is just demonstrate how to measure for Pulsus Paradoxus, and we're actually going to give John Pulsus Paradoxus and measure that again and show how we pick it up. He's going to survive. So thank you. Poonam is going to help us with holding. So normally for Pulsus Paradoxus, all you need is a stethoscope and a blood pressure cuff. But when we demonstrate it, we actually use a Doppler instead of the stethoscope, so we can put the sounds up on in the whole room. Great. Okay. Yeah, left arm works, whatever you like. We'll put the...
Would it be easier with...
Sure, we can do right side too.
Whichever you think.
Yeah, those are left arm, I guess. Okay. Alrighty. So when you're doing this, instead of with a stethoscope, you don't have to put it too high, but with the Doppler, you want to bring the cup up a little bit higher so there's room for the probe to go. And if you can do this as just one person, but in general, it's better for two people because as you inflate the cuff, the cuff gets bigger and sometimes it pushes the probe away from the artery and you lose the sound. So it's good to have someone whose job is pretty much dedicated towards looking, towards holding the probe. And I can hold that for you. Okay. So what I'll do is we want to get a camera on this guy. Maybe I can hold it. Put it there. Can I get you to actually? Maybe we yeah, this is fine. This is fine. Okay. So what we'll do first is we're going to just measure him in normal without Pulsus Paradoxus, we're just going to measure his blood pressure. So what we expect to see here is his blood pressure. What we're trying to do is get this blood pressure where it first starts to appear. The court cough sound first starts to appear. And what should happen is when you first hear it and you take a deep breath in, it goes away, right? Because the blood pressure dropped a little bit as you took that deep breath. Then we want to keep going down by 5s to the point where the blood pressure, the sounds are consistent. And that's that second reading. So the difference between those two readings, where you first hear the court cough sound and it goes away when you breathe in, versus when you hear it again and it's persistent despite breathing, should be less than 10. That's normal. Try that. Okay. You can hold that? Okay. Perfect. Okay. So wait for it to go away. John's blood pressure a little high right now. Totally understandable.
The stage is a little hot.
So 155 is gone. So let's get it back at 150. Take a deep breath in. Deep breath in. So it goes away. So about 150, 150, let's say it goes. You see that at 145, it's persistent? Do you guys see it go away at 155? Deep breath in. Big deep breath in. See it go away at 150 here, and it comes back when he breathes in? So it's a little hard to see now. We just like to show you what's normal. We're going to make it easier to see in a second. We're going to give him Pulsus Paradoxus. It'll be easy to tell the difference. We'll give you a quick break. I'm going to get a straw. You guys know the situations where you get Pulsus Paradoxus? So cardiac tamponade, really bad constrictive pericarditis. A few other ones. One of them is in an asthma attack or COPD exacerbation. The reason why is you're just creating such negative intrathoracic pressures. By taking the deep breath in, you're causing more blood to go into the right side and just less blood can go to the left side, and you're dropping your pressures more. And so we're going to mimic an asthma exacerbation in John by having him breathe through a straw in and out. All right.
So I may not be as vigorous as last time when we were practicing this. We got it pretty high before, but I may not go that bad.
Yeah, our residents tend to turn this into a competition, see how big the numbers they can make it. I should note, when we go to small groups, simply not using a straw and taking big deep breaths in, you can make that pressure good. So if you don't have to both your straw, and please don't if you don't trust your ability to stay upright after doing so. Okay, good. Can we turn it 90 degrees? Good. See that? So I'm going to go down by 5 or 10 and just keep checking to see if he's 120. Let's try 100. It still goes away a little bit, but it's starting to come back. So about 95 for sure, it'd still be persistent. So it's still, okay, you can stop. Thank you. All right. Thank you. So about 140 to 95. And so that's exactly what you do if you have a patient on the inpatient setting and they're tachycardic, they're short of breath, maybe you hear distant sounds, right? You can throw an ultrasound on there and see fluid around the heart. Then we do Pulsus Paradoxus. We know immediately if they're in cardiac tamponade or not. So these are the types of things we want our residents and doctors to know at the bedside. Thank you very much. Great job. So guys, that's basically what we, so that's 2 Stanford 25 sessions in a very short amount of time. Certainly what we would do in a real session is put it together with a clinical case, talk about the different things you'd see or may not rule in or rule out a concern for tamponade, and have the residents practice Pulsus Paradoxus on each other with the straws. Do we have time for questions? Are there any questions about any of that? Anything I talked about, Stanford 25 sessions? I just want to comment as well. I've talked to a few of you guys, and a lot of you guys already are doing some great stuff like Stanford 25 sessions. Melissa Rousseau at University of Ottawa is doing sessions where they have different ones teaching senior and junior residents. Brian Garibaldi at Johns Hopkins has recently started what I hear is probably an amazing session. He's going to join us on the panel tomorrow. And I imagine there's a lot of great stuff being done by many of you guys. So I'm really excited to hear what you guys are doing and how we can help you. Yes? Yes. So we do. So no financial support by Welch Allen. They are the only ones who make something. It's actually this genius guy in the South, an ophthalmologist, came up with this eye examiner, and I'm pretty sure he made more money off that than being an ophthalmologist. He sold the rights, the patent to Welch Allen, and they got FDA approval, and they sell it. We did speak with them, and they do have so the whole kit, the iPhone, the Panoptix, the whole thing costs generally $1,000 for the kit. There's a significant discount, and we have a link if you guys are interested in buying. Again, this is something we just did for you guys. We don't have any ties with them whatsoever, and we're happy to connect you with that if you're interested. Yes, we went on Amazon, a bunch of iPhone 4s just for the symposium.
I was recently rounding at our CCU, and I found a resident checking for a paradox in a patient that had an art line in.
Yes.
And when I pointed out to him that you could use the art line, it was like a light went off. So I think that's important that they understand the physiology of what they're looking for.
Yeah, that's a great point. If you're wondering how much they're actually critically thinking when they're doing this, as opposed to just following the mechanics.
They know the right thing to do, but they don't always know why they're doing it.
You don't even need an art line. You can use a pulse oximeter. It comes and goes.
You can use your fingers on the radial pulse. I mean, you can, in somebody that has severe paradox.
Absolutely. Thank you for that. Thank you for mention that. Yes.
Like their breathing can become more exaggerated if the patient's aware of it? Do you tell them to?
One of the differential is simply deep exaggerated breathing can pretty much do what we just mimicked here. So yeah, they should be breathing normally, and you have to, these are little subtleties. This is why the teaching at the bedside is so important. These little subtleties can make a life or death difference in how you interpret something. So yes, you should ideally not tell the patient to take deep breaths. Don't coach them to overbreathe. Basically, you can increase the numbers, you can overestimate the numbers. Thank you. Thanks.
A little housekeeping tip which may help people who are here. So you mentioned you use real patients. So the problem we have is finding those patients. And so I go around the hospital asking people, do you have somebody in this and that? So what we've done is we all have electronic medical records now. So we've formed a kind of a subfolder in which everybody, if they have something interesting, they put it in that folder. So I have that updated folder every day, so I don't have to keep on texting or emailing and all that. So
we'll have to talk more about that.
Yeah, so
I love it.
Yeah.
Thank you. We don't use real patients. We don't wheel in patients. We worry about cardiac tamponade to our classrooms, just to mention that. That's why we use the straws. Yes, actually, do you mind bringing the mic, Aaron? Thank you. Oh, do these work?
I was just curious about numbers because some of those classes were quite large. So how do you get, like for Pulsus, for example, that's a long activity for every learner to try during a session.
Luckily we have a big box of straws. We just hand them out and give everybody. So that's actually one of the ones that is relatively easier, except that we need to have more facility members to go around and help them when there's more of them. We actually, when we first started off, the residency program asked us to do it on a day where all the outpatient and inpatient residents showed up, and we had like 50 residents, and but that number, actually I didn't show you a graph where about 25% of our residents are always, we ask them a question, how is the size? Too big, just right, or let's fit more people in? No one ever puts the let's fit more people in, and about 25% of the time people say we would have wished that there's less people. So it's still an issue with us. We really take that serious too, because this is all about intimate kind of bedside teaching. The problem is the time issue of, and the labor of getting patients and organizing this thing is a limiting factor. We're hoping to improve on it.
Do you standardize the training of the faculty? And if so, how frequently do you guys come together and make sure you're teaching the same thing over and over?
We don't. In fact, we encourage a little bit of variation. One thing I didn't mention that, that you're reminding me of is, so I showed a picture of Poonam teaching the knee exam, and then I showed another rheumatologist teaching knee exam. His name is Mark Genovese. And we actually find that I've learned so much myself, let alone the residents, from learning how one person does a knee exam versus how somebody else does. It's really hard to standardize that teaching because you're really teaching the experience. There's certainly overlap, but there's a lot of different things that oftentimes aren't covered by different people. So we actually kind of encourage the variability. We want to get more people teaching that. We have multiple people teaching the lymph node exam, for example, and I always learn something different and new. Certainly if there's something that conflicts, then we want to make sure that's not happening, but generally that's not an issue.
I have a question in terms of, it sounds like this has been being done around the country as well. Do you guys know what are we actually teaching at these sessions? Because I'm trying to figure out if you actually critically assess this. Are these sessions where you actually, do you ever measure like a week later, can they actually do the exam skill? Are these sessions where we're demonstrating professionalism? Are these sessions where we're focusing on teaching of the skill?
Yeah.
What do you think we should be measuring to see whether these are actually?
No, I'm really glad you answered that question. That's been a question we've been asking ourselves as well for a long time. In fact, we are going to touch on that a lot tomorrow, the notion of assessment. In this country, we do a horrible job of assessment, both at a national level and certainly at individual level. Our best assessment at this point is a lot of some of the survey data. I showed you a little bit of what we do. We've been working on developing a kind of a mini version of what Andy is going to speak in greater depth about tomorrow of an assessment. But outside of that, I can't answer your question because we haven't done enough of it yet.
So you haven't tried coupling this to like a post-quiz?
We haven't done. We haven't done a post quiz. No, we haven't. I'll tell you, just getting them to fill out that survey, it's like they're running out the door back to the wards, and we're like running after them to write. We haven't been able to do that yet, but that's a great idea, and it's something we've entertained. We just haven't done yet.
How do you recruit your standardized patients, and how do you reimburse them, and how much?
Yeah, so we reimburse them. We pay them $100 to show up for an hour. And that kind of mixes in with any parking fees and whatnot. A lot of patients we have oftentimes will just say, no thanks, I'm just happy to do it. But most of them are happy to take the $100. We recruit them in any way we can. We reach out a lot to outpatient docs. So a lot of our group is inpatient docs, but we also have a growing number of outpatient ones. And I run into a patient in the inpatient, I'm always asking them to, and we have a running list of patients. And the patients come and go. Their exams, one of the issues is, the good thing is a lot of times their exam findings go away and improves. Our patient with CLL, actually, we had to get another patient with lymph node because he got treated and he has no more lymphadenopathy. It's an ongoing dynamic process to keep a list of patients.
I'm curious about the ones that you said were the actors. How
Yeah.
do you standardize and teach them? You're saying these are real clients.
We have two different groups, yes. Some sessions we do standardized patients, some we do real patients, some we do both.
So how do you recruit the ones that are not real patients?
Oh, so our medical school has a connection with our standardized patients because they use them for OSCEs, one for the medical students, so we go through that mechanism. And that's why they're all professional. They're already trained, and they're really great at giving feedback. And as I mentioned, they're actually, most of them are actors, and they're really good at acting out what we need them to do.
With medical problems where the examination repeated times could be uncomfortable for the patient. So for example, splenomegaly, where learners really enjoy and benefit from doing the examination, but honestly 50 patients couldn't examine a spleen and a patient be willing to tolerate that.
Yeah.
What do you do to maximize the learning in that kind of setting?
Well, we apologize to the patient a lot. Now, I honestly, to be honest with you, it's just one of those things where I stand by the patient, and every third resident comes by, I'm like, "Are you doing okay?" And a lot of times they'll just say yes no matter what, but you can sense if they're comfortable or not. And at a certain point, you stop. For the most part, we haven't, especially as we lowered the numbers, we haven't had that problem. I would say one of the biggest things that will make us cut the sessions down is if we run into something like that, where we literally can't even just get all the people in the room to do a simple examination of a spleen. that's something that's a really great finding that you really have to take advantage of. If we can get everybody to do that exam, that would be at the moment we say, listen, the Stanford 25 sessions are now cut in half moving forward, and we'll figure out a way to deal with it, which we're eventually moving towards anyway.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.